So Dr. Hall and I are co-directing this course, and the purpose of this webinar, just to give you some history, they did a webinar one time before for the ultrasound course going on next week in Las Vegas, and then they did a survey after the webinar to kind of get people's reactions and decide how people liked it or not. And the one comment that people made was that they wanted a little more educational content and not just kind of a preview of the course. So what I tried to do here, or what Dr. Hall and I tried to do, is take a 2-day course and give you little bits of what we're going to be teaching you for 2 days and put it into about a 25-minute talk, as well as kind of preview the venue that we're going to be talking about and going to for the course. And like Jose said, if you want to ask questions, there's a mechanism to do so, and he will filter those questions, and I probably won't get to them until the end. But if you send them in, if we have time at the end, I'll answer as many of them as I can. So this is kind of our agenda here. We're going to talk about tendinopathy in general. We're going to talk about the use of MSK ultrasound and diagnosis and treatment of tendon disorders. I'm going to go through a clinical case, which is possibly a case we're going to present at the course as well, and then do the course information at the end. So to get started, talking about chronic tendon pain, I think all of us probably see this in our practice as physiatrists, especially with our interest in MSK ultrasound. I think we're in a unique position to really treat this patient population. We know it results in lost productivity, sport, recreation, and certainly quality of life. The biggest misconception out there, and we still see it every day, is the misconception of inflammation in the tendon process, and the misconception of the treatment that you rest, you avoid activity. These are very old school orthopedic treatments, and a lot of our course is going to be dispelling a lot of these rumors and talking about current day modern treatments for a multitude of tendon problems. So how do we know that there's no inflammation? Well, histologically, we've seen this as well. We looked at prostaglandin levels, and Achilles tendon and many other tendons have shown that they're normal prostaglandin levels. We know there's no upregulation of any pro-inflammatory cytokines. Thus, the term tendinitis become misleading, and it's really something that we've been trying to get away from for quite some time. We know histologically there's a lot of collagen fragmentation, disarray, that there's abnormalities of the tenocytes. They have programmed cell death. There's a lot of excess glycosaminoglycan production as well, and once again, lack of inflammation. So collectively, we call these degenerative features tendinosis. Now, we're not always faced with the ability to see the tendons, and so we're kind of left with this kind of algorithm of the definition, and hopefully in the course we'll be correctly using these. So we know tendinitis is very rare. Even when someone comes to your office with 2 or 3 days onset of acute tendon pain, we know a lot of times that tendon process has been going on for longer, and we're just seeing the time when they reach that level of pain threshold to become painful, and it may even not be an inflammatory condition at that time. So we like to use the word tendinopathy, which is the clinical diagnosis of the pain, swelling, and impaired function of a tendon. And then when we get to our ultrasound portion, we can visualize the tendon, which we're going to go over some. We'll often again see what we will call tendinosis as the predominant feature. So there's really 2 models of a degenerative tendon, and even now, we don't know the exact mechanism of pain and the etiology for tendinosis, and we're going to go through a lot of theories in the course, and I'm going to briefly mention them here. But I can basically narrow it down to 2 models. One is the degenerative tendon model, which, especially in the United States, tends to be what we mostly go about in diagnosing and treating tendinopathy. And basically that model is the failure of a tendon to progress through its normal healing cascade. So there's some maladaptive response to increased demand coupled with potentially a biological tendon that was prone to be overused, and some combination of extrinsic and intrinsic factors as well. The course is going to go through a lot of different treatment algorithms, including conservative treatments, before we get into all the ultrasound and interventional treatments. We know for this degenerative tendon model that physical therapy, we probably all know that eccentric strengthening has been proving in certain tendons to be of extremely high benefit. We'll go through some of those studies of which tendons seem to work better with that. Nitroglycerin patches is an emergent treatment that may be used more in some other countries, but the providers who use it here as well to treat tendinopathy. And then you get into a lot of the things that this course is going to highlight: percutaneous needle tenotomy, PRP, prolotherapy, BMAC, stem cell treatment, adipose-derived stem cells, and I highlighted PRP because we'll spend a considerable amount of time discussing PRP. Without going into too much detail, that's a very common term, obviously, and there are different preparations of PRP. We'll go through what all the variables are with platelet counts and red blood cell count and white blood cell count and all the studies, and say what we know and what we don't know about PRP and its application and stuff. So you won't come out of the course with, we want you to draw your own conclusions for which of these you want to institute or start to use more of. We'll give you the rationale for each of their use and talk extensively about them. Now, what's probably more interesting and emerging, especially in this country, is this neurogenic inflammation model. And basically, if you read a lot of the Scandinavian literature, Dr. Alfredson and the Europeans and the British researchers, Dr. Mafuli, they talk a lot about the pain and structural abnormalities that are mediated by these neovessels and neonerves outside the tendon. Now, the whole concept of neovascularization, which we'll talk a little bit more about, is somewhat controversial in terms of how much this plays a role in pain and in the treatment of tendinopathy. But needless to say, there's a whole bunch of folks who are centering their treatment outside the tendon. They never go directly into the tendon. So we do a lot of PRP and needle tenotomy in this country, and over there they do a lot of sclerosing injection, which has somewhat been replaced by these ultrasound-guided scraping procedures or surgical scraping procedures. We'll talk about these high-volume image-guided injections, which there's some evidence on as well. And this is something that we'll focus on in the cadaver lab as well in terms of practicing these procedures. And we'll go through kind of the rationale behind treating inside the tendon problems and treating outside the tendon problems. And the only other caveat I'll say is that because of there is still debate about what the actual pain generator is outside the tendon, there are probably other biochemical issues that we don't even know about. People talk about the TRPV1 receptor and other cascades that may cause pain, and we'll talk about what we may actually be modulating when we're treating these outside the tendon problems to try to get the inside the tendon problem to get better. So diagnosis of tendon disorders, kind of going back into looking at tendons with ultrasound. We know history and physical exam are key, but we're often unable to provide a specific diagnosis. So I probably don't have to mention a whole lot about the advantages of sonography. I think most of y'all have probably do an ultrasound to some degree in your practices already. We know from a diagnostic point of view that the accuracy, is comparable to MRI, especially with tendons. There are multiple rotator cuff studies showing a very good comparison of MRI to ultrasound. Obviously, it's extremely operator dependent in that realm. We know ultrasound has the ability to do dynamic evaluation, dynamic exams, which no other modality can do. We talked a little bit about neovessels. I'll show you a slide on that later, talking about how ultrasound is the only thing that really can show us neovessels as well. We know about the cost savings compared to MRI. In my institution, an ultrasound is probably about 1/7 the cost of an MRI. And so obviously we know that will be extremely important moving forward with the changing in healthcare and the cost savings that are going to be needed in healthcare. The point of care service with ultrasound, we know there are a multitude of studies that have shown improved accuracy with intervention. We can get to the target area better. Now, there are not quite as many studies showing improved efficacy, but that data is emerging as well. There's even data that's starting to highlight improved cost of patient care with ultrasound-guided intervention as opposed to palpation-guided intervention. And moving forward, once again, in healthcare, I think that's going to be important too. And patient satisfaction, there's a lot of studies showing that patients are more satisfied with ultrasound-guided procedure because it's less painful, it works better, and they enjoy the interactive and the technology of the ultrasound procedure. So this is probably a review, but looking at a normal tendon here, for most tendons, especially superficial tendons, we're going to be using a high frequency, a linear array transducer. In the long axis, which you see on the bottom of the screen, and you see the accompanying photo here, we're looking for a fibrillar, tightly packed pattern, linear echoes. In the short axis, it's going to be, people describe a broom end appearance or a stippled cluster dot appearance to the tendon that you're looking at. And this is just showing the difference in the tendon. Deeper you have muscle and even bone kind of in that area as well. And they all have different, obviously, acoustic shadows that they produce. And we're in this course, obviously, you will be looking at muscle and bone, but we're really going to be focusing on diagnosis of tendons and looking at, what tendons look like with ultrasound, both normal and abnormal. So in talking about tendinosis, typically the findings, which the top portion is a long axis view of a patella tendon. You see the normal area of the tendon, which I'm showing with my arrow, and more proximally, you see thickening of the tendon. It's hypoechoic, meaning it has less echoes than the surrounding tissue around it. It's heterogeneous, and you may or may not see enthesopathies, which are calcific projections off of the bone here. A lot of times you'll see enthesopathies that you would never see on an MRI, you'll never see even on a plain X-ray because of the spatial resolution that ultrasound provides. You may see calcifications. You may see flow on Doppler. We'll talk about that in the next slide. Once again, this is an Achilles tendon and shows a large mid-portion non-insertional Achilles tendinosis with thickening, fusiform thickening of the Achilles tendon, hyperechoic heterogeneous signal throughout the tendon, but no focal tears noticed on that view. So we mentioned neovascularization a lot, and we'll be talking about this a lot in the course, and we all know that how important this is in looking at tendons. If you look at the top picture here, this is showing power Doppler, and these two images here are showing a color flow Doppler. Power Doppler is not as sensitive to, it doesn't detect direction of flow, just flow, so it's more sensitive for flow though. What we'll talk about is the role of neovascularization and whether it's associated with pain and whether we should target it with our interventions. And if you look at some of the more recent literature, it's starting to question how much it is associated with pain, meaning that you can have a normal tendon, or I should say non-painful tendon with neovascularization. You can have a extremely painful tendon where there's no neovascles. And so the theory being that the nerves that run with the neovascles are the source of the pain, but in practicality, a lot of studies show there's really not that much of a correlation, although when we target these, we do often find improvement in symptoms, whether it's through this mechanism or another. Looking at partial tendon tears, the difference between tendinosis and tears, and realize that most of the time when you see a tear in a tendon, especially a partial tear, there will be background tendinosis. So for this patella tendon here, you have a thickening of the proximal patella tendon, but there is also an undersurface tear, which is usually more well-defined. You will usually always want to be able to see it in orthogonal planes or two planes, and it won't be anisotropic, meaning when you rotate your transducer, you won't be able to fill it in no matter how you toggle your transducer. We look at these more at critical zones where there may be reduced blood supply, undersurface of tendons, watershed region where there's a lack of blood supply where you may be more likely to see partial tendon tears. And dynamically, you won't see retraction. We'll show you a full thickness tear with retraction in a minute, but always use your dynamic imaging when you're looking at these tendons. So for a complete tendon tear, you want to, once again, control for anisotropy. You want to look for a gap versus an absence of a tendon. Not sure how well this top picture is coming in on your screen, but there's two markers here where there is absent of the rotator cuff tendon. You can see on the right side of the screen a little bit of rotator cuff tendon there, and then a gap where there's no tendon, which represents a full thickness tear. You see the intervening lines of the deltoid muscle above it, and then the lack of tendon here. And in an acute tear, normally there'll be fluid, so it'll actually show it better because the anechoic fluid will highlight your tear better. This is probably more of a relatively acute tear as well because there's not volume loss yet where the deltoid is not invaginated down and taking the place of the supraspinatus tendon, which it can do. Chronic tears can be harder to read, especially complete tears, because you may get scar and fibrosis in that tear, which will look a little bit like tendon, and so we may need to use other ways to differentiate it from tendon. But you want to be able to identify the ends of the tendon. Dynamic imaging is a good way to do that. If you look at the bottom of the screen, this is a patella tendon distally. You can see some tendon fibers here. It looks really abnormal. This is the tibia here, and you may be wondering whether or not this is a complete tear or just a severe tendinosis and partial tear at the distal patella tendon. When I passively, the patient could not actively extend their leg, when I passively extend the leg, you can clearly see here the tendon here and the complete separation from the tibial tuberosity below, indicating a complete tear of the distal patella tendon. We talked about dynamic imaging. I have a few examples of it on this slide here. A few common areas where you will see snapping tendons, and patients always come in and tell you about their tendon that are snapping. And although you may clinically be able to guess what it is, ultrasound gives you a much added ability to make a diagnosis. You can see in this picture here, peroneus longus and brevis tendon. The longest is right here. The brevis is closer to the bone. And the reason why this is snapping is because of a split tear in the peroneus brevis, which is almost forming a dumbbell or circling around the peroneus longus above it. And you can see the snap back and forth. So it's not just a snapping tendon, it's a torn tendon that is subluxating around the peroneus longus. This is a snapping iliopsoas tendon. We used to think that the snapping of this tendon, which you can see right here, occurred over the femoral head, which is right here, or over the iliopectineal ridge. John Jacobson described a couple years ago that a lot of the time the snapping actually is an internal snapping within the muscle itself, which you can see here. This is the iliopsoas muscle, which is more hypoechoic than the tendon here, and you can see the snapping occurring right there, back and forth, as the patient goes into a flexed and externally rotated position, abducted externally rotated position. And then the last one here is an IT band snapping, and so the right is anterior where the glute minimus tendon is. Over here is the lateral facet where the glute medius tendon is, and you can see the IT band snapping back and forth over the tendon. You can make that diagnosis pretty easily, and also once again see, are they snapping because they have a thickened IT band? Do they have a bursal fluid there that's causing the snapping, a tear, or what the true pathology is? All right, so a few minutes of a clinical case, and then I'm going to go through the course description and be done in about 10 minutes, so or less. 45-year-old active female flight attendant. She had a long history of Achilles issues. I'll go through the history rather quickly, but she's seen multiple doctors. She was prescribed traditional treatments, heel cup, NSAIDs, physical therapy, multiple times, stretches, anti-inflammatories at her second doctor visit. Foot and ankle surgeon she saw. Second foot and ankle surgeon who then offered surgery. Now, at the time, she was having both insertional and mid-portion pain. They decided to treat the insertional Achilles tendon, thinking that would solve her problem. They did a Haglund incision, burrsectomy, and a reattachment of her tendon. This was May of 2011, and she had had almost a year of symptoms at that point. She didn't come to see me until January 25th, 2012. Some of this case is fragmented because I couldn't have all of her old ultrasound findings because I switched to a new machine and I couldn't find some of her work. So this isn't actually her, but she did have post-surgical changes at her insertion. But the reason why she was there is she was having mid-portion Achilles tendinosis, which she was pretty severe. She had some neovascularity as well. Now, what I want to point out to you, and this is, once again, not the patient, but a representative of what I've been looking at a lot more lately, is when you're looking at an Achilles tendon and you're looking at its insertion here and you're looking at Kager's fat pad, on the normal side here, you see the glide of the tendon, you see the glide of the fat pad. There may be some adhesion here, but everything is moving pretty smoothly. This is the same person, but on their symptomatic leg. And now if I look at this Achilles tendon, you notice a couple things. First of all, there's not as much motion in the tendon at all. Second of all, obviously you see the thickening of the tendon, but more importantly, look at this fat tendon interface here, and look at how the fat is almost invaginating or adhering to the undersurface of the Achilles tendon, and there's not much glide here at all, especially right here underneath the area of right where the enthesis is. So the thought is that maybe this is a patho mechanism of pain for these patients, in addition to the tendon abnormality itself. So getting back to my patient here, after going through all this treatment, we did a PRP injection. She reported less than 50% improvement at 3 to 4 months. And so, you know, we went through the option which you would probably think about for a similar patient: continue physical therapy, repeat PRP. We talked about doing PRP with adipose-derived stem cells or bone marrow, but we ultimately decided on this high-volume image-guided injection, which I call a high-volume ultrasound guided scraping, because I kind of combine the Alfredson and the Mafuli technique, and we'll talk about what that means. So basically what we did on this patient is we went in and we went in with the needle and the short axis, like that is showing you up here, and we went underneath the tendon. Sorry, I'm going to start that over. We went underneath the tendon, right with the fat pad interface, and this is actually the patient who we did this on, and we injected a volume of medicine to try to separate that fat pad away from the tendon. And you can see on this third little cine clip here how after much work you can start to see separation occurring. And you will check, a lot of times you'll check Neovascularity pre and post to see if you're getting your desired response. Now, she did have an initial 50% improvement, but her pain returned and now was almost at pre-baseline level. So now she has failed a PRP injection, she has failed a high-volume injection, and we're running out of options. So these were the options we discussed with her that time, and we opted on doing a 10x FAST procedure, which some of you are familiar with. Basically, this is a percutaneous procedure that's done by non-surgeons like all of us, where we take, well, probably all of us, where we take a device and it will cut and debride diseased tissue and spare healthy tissue and actually aspirate out damaged tissue and tendon. So I used this device in a little bit of a different mechanism. Instead of doing intratendinous procedure with this, I actually went short axis under her tendon at that fat pad tendon interface, thinking that I really wanted to separate that out. And so this is just going to be a short video clip, but here's the short axis of the tendon. You're going to see the needle coming in from the right side, or I should say this is the 10x the device coming in, and then it will pulsate at about 27,000 oscillations per second. And I basically created a separation and obliterated some of that fat tendon interface. And so her follow-up, at 2 weeks, you had 90% relief of pain. And you can see these are actually her images here. You can see now she had this line. This didn't go all the way across. Some people describe this as a smiley face sign. Didn't quite go all the way across, but certainly there was some separation here in her tendon from the fat area. If you look here, you can see that as well. And what I thought was more impressive, and she is still 90% improved right now, but this is her as well. And I'm going to show you a video here, and all of a sudden now we've restored a lot of that natural glide. So there's still a little bit of fat adhered here, but we've disrupted that fat tendon interface, and her pain is gone despite the fact that her tendon still has some thickening here. She has some post-surgical changes still at the enthesis. It'll never look normal, but she's finally feeling better. So that's the kind of cases we're going to go through as well, kind of putting everything together. That's at the end of the course. Okay, so a few minutes here on course information, and then we can answer any questions if there are any. Basically, the course is set for May 17th and 18th. It's going to be in Tampa, Florida, at the Center for Advanced Medical Learning and Simulation. I've never been down there, but I heard this is a state-of-the-art facility, and AAPM&R is excited about going down there. You can see the rates here for member and non-member. Registration is open. We're going to have lecture. We're basically going to go soup to nuts on treating tendons. We're going to go from the basics of diagnosis to conservative treatment to interventional treatment, with a good bit of time devoted to hands-on scanning as well as hands-on cadaver work. So over the 2 days, it'll be 10 hours of hands-on instruction, either in the cadaver lab or with live models. We have some of the most influential and important people in our field coming to teach the course. From radiology, John Jacobson is coming. Greg Sabero from HSS is coming. He does a ton of interventional ultrasound. We have Brad Fullerton, who's a world-renowned prolotherapist, a physiatrist who really has a lot of knowledge on this area. We have folks like Marco Bador and Jerry Malanga, who do a lot of interventional procedures and stem cell and PRP. Mike Fredrickson, who's an expert in tendinopathy, will be talking about some conservative management as well. And so we really feel like we have a top-notch faculty who will be teaching you all of which will be able to really answer questions and take us through really the state of the art right now. There will be 2 hours of free scanning as well built in, where you can kind of pick your own adventure at the end and do whatever you feel like doing. I should say that the cadaver portion is really going to focus on the technique of getting the needle in the tendon and the technique of kind of getting under the tendon and that fat tendon interface for an Achilles or a patella tendon issue. And what you put in your needle we'll talk about, but we'll leave that up to your own practices. Here's the hotel information. Here's the AAPM&R rates. We're 1 block from the facility, so, sorry, 2 blocks from the facility, 1 block from the waterfront, so you can easily walk there in the morning, although, and we're close to the airport as well. There is a trolley that runs to the hotel. There's a trolley that runs to the nightclubs as well and to the Ybor City, and so there's easy access to get around Tampa, although we have long days in the course. There's a baseball game the night before, which if y'all want to come in on that Thursday evening early, you can go to the Tampa Bay and Red Sox game. And there's jogging trails as well. One other thing we're going to be doing 6 weeks after the course, anyone who's registered for the course will be able to do an Ask the Experts conference call. We don't have a lot of details on this, so this is kind of a new thing AAPM&R is doing, but you may go home, start doing some of these things, and have questions in your practice, and you'll have a chance to talk to some of the faculty from the course and have them answer questions that have probably come up since you left the course. And with that, I am done with my talk. If there are any questions and you haven't submitted them yet, this would be the good time to. I'll wait a minute or two and see if anyone has any questions before we let you all go. No one submitted any questions yet. I'll give it a little more time. You can see the website for AAPM&R. As I said, type in ultrasound, and you know we already have people registering for the course, so feel free to hop on anytime and sign up for it. And we'll give you all just a little bit longer in case there are any last-minute questions. Okay, so I just wanted to thank y'all for coming on board and listening to this webinar. Oh, there we go. We got a question. The question is, will we have 10x there? The answer, I'm not sure about the answer. I know that the 10x folks have been in talks with the marketing folks, you know, as we're setting those sponsorships. We will have a lot of the PRP companies there, and I know 10x was interested in being at the course. But I don't have confirmation if they're going to be at the course or not. Maybe at some point you could ask somebody who in marketing or someone with PM&R if they're going to be there. But it will be discussed a little bit in terms of when we use it, how we use it at the course, and I expect that they probably will be there at the booth with some of the other PRP companies who will also be there. And for those who don't know, the 10x was that fast procedure that I showed with that case that I did in the clinical case. All right, looks like no other questions. Oh, one other question. Can we bring our own ultrasound machine, or our own machine? I'm assuming you mean ultrasound machine and not 10x machine. Can we bring our own ultrasound machine Well, I'll answer both questions. Can you bring your own ultrasound machine? You won't have a need for an ultrasound machine. We're going to have machines there from a lot of different companies, and so we're going to prefer that we use those machines in the course and with the cadavers. If you have a 10x machine and you're asking about whether or not you can practice with the 10x device in the lab, I don't know the answer to that. I would probably refer that on to the folks running the administrative people. But I will say that you know, we're going to have 4 or 5 people per group, and if we have someone using a 10x device, they're probably going to obliterate that tendon pretty quickly, and it probably won't be fair to the other people trying to get practice time on the tendon, doing other needle techniques. So I would imagine we probably would not like to use something that would kill that tendon when we need 4 hours of poking needles into it. One more question I have here is, how much background would you suggest someone have prior to taking this course? It's a good question. This is an advanced ultrasound course, so AAPM&R has kind of changed the way we're running our courses now, so we're going to have basic, intermediate, and advanced level courses. So all the previous advanced upper and lower extremity courses have now become intermediate courses, and we're hoping that everybody who comes to an advanced course has at least done a basic course, but most likely has done a basic and some kind of intermediate course. We're not going to be going through the physics of ultrasound at this course, and there will be some stuff available online, I believe, before the course in terms of some lectures we have on physics. But we're going to be jumping right in to tendon disorders and tendinopathy and interventional techniques. So we would expect that people have a basic knowledge of how to diagnose tendon disorders, how to hold the transducer, how to play with your knobs and your buttons in your machine, so that we're ready to do more advanced techniques.